let Dr. Bhattacharya join. Okay.
Okay, sir.
Good morning. Today we have a seminar presentation on fluid electrolyte balance in surgical patients. This is a very important topic for surgical residents because we need to manage fluid in our day-to-day practice, and there are a lot of confusion and misconceptions in planning fluid therapy. I hope seminar today will clear some of our doubts and we'll be able to formulate a rational fluid therapy for our patients in the ward and in critical care. So I start this session with Behrul Huda, who is a junior resident at Southeastern Railway Hospital. So he'll talk on the normal fluid and electrolyte physiology in the human body so that we can understand the deviations. So Behrul, you can share your screen and start.
Yes, sir. Good morning, sir. Myself, Dr. Behrul Huda from Southeastern Central Railway Hospital. My topic of presentation is fluids and electrolyte physiology. First of all, in body fluid compartments, water constitutes 50 to 70% of lean body weight. Am I audible, sir?
Yes, you are audible. Carry on.
Yes, sir. Water constitutes 50 to 70% of lean body weight. Total body water is divided into an intracellular fluid compartment and an extracellular fluid compartment, which consists of an intravascular compartment and interstitial compartment. The extracellular and intracellular compartments have distinct electrolyte composition. The principal extracellular cation is sodium, and in the principal extracellular anions are chloride and bicarbonates. In contrast, the principal intracellular cations are potassium and magnesium, and the principal intracellular anions are phosphates and negatively charged proteins. Osmolality and tonicity. Osmolality refers to the number of osmoles of solutes per kilogram of water, and is comprised of both effective and ineffective components. Effective osmoles cannot freely permeate cell membrane and are therefore restricted to either the intracellular or extracellular fluid compartments. The asymmetry in effective osmoles between these compartments cause the movement of water across the cell membrane. The effective osmolality of a solution is equivalent to its tonicity, and in turn, tonicity is the parameter the body attempts to regulate. We can easily calculate the total body water by, as we know, all 60% of total body weight is water. So we can calculate it by 0.6 into body weight, and total body water equals to 2/3 is intercellular fluid and 1/3 is extracellular fluid. And we can calculate by easily by intercellular fluid equals to 0.4 into the body weight, and 1/3 and ECF equals to 0.2 into the body weight. For example, for a 70 kg of adult, total body water will be equals to 0.6 into 17, that will equals to 42 liters. And similarly, intercellular fluid will comes equals to 28 liters. And blood is the 8% of total body weight, and plasma is 5% of the total body weight. As in the pictorial diagram, we can see total body water is divided into two: intercellular fluid and extracellular fluid, and further extracellular fluid is divided into two compartments, that is intercellular fluid and plasma. We can measurement of body fluids. We can measure the amount of body present in our body by a principle called Stewart-Hamilton principle. It is a dye dilution indicator method in which a small amount of dye is instilled in our body, which gets distributed to all compartments of our body. So the formula is V equals to I by C, where I equals to initial amount of dye injected, and C is the concentration of dye after it got uniformly dispersed. So, if in case of a dye get excreted from the body, we will have to subtract the amount in the numerator, where I will be equals to the amount of dye instilled, and subtracted by the amount of dye excreted from our body. So the indicator used for measurement, different indicators are used as different as some indicators can easily can enter all the body parts of our body. Like for total body water, we use deuterium, tritium, antipyrine, and aminopyrine. And for extracellular fluid, we use insoluble monosaccharides like sucrose, inulin, and mannitol. And we measure the intracellular fluid by indirect method, in which we um, subtract the ECF from the total body water. And plasma volume is measured by radio labeled iodine, and red cell volume is measured by 51 chromium tagging of the RBCs. Now, disturbances in body fluids. Basically, there are two type of disturbances, that is dehydration and overhydration. Dehydration is loss of water from our body. It is of three types: isotonic dehydration, hypertonic dehydration, and hypotonic dehydration. In the isotonic dehydration, water and sodium are lost equally from body. It is seen mainly in GI fluid loss, burns, and hemorrhages. Whereas in hypertonic dehydration, uh, uh, water loss is much more as compared to sodium loss. It is seen in case of diabetes insipidus and chronic alcoholism. While in hypotonic dehydration, sodium loss is much more as compared to water loss. So all these references are as in comparison to the extracellular fluid compartment. And hypotonic dehydration seen is mainly in hypoaldosteronism. Overhydration is also divided is of three types, that is isotonic overhydration, hypertonic overhydration, and hypotonic overhydration. Isotonic overhydration means administration of normal saline and oral IV saline, which is isotonic to our body, that is 0.9% saline. Whereas in hypotonic overhydration occurs when when we administer 3% saline or 6% saline, which is hypertonic to our body compartment, body, to our extracellular fluid concentration. And hypertonic overhydration is seen in case of syndrome of inappropriate antidiuretic hormone secretion, in which uh, excess amount of aldosterone is secreted from our body, which causes sodium retention. Ultimately, from the atrial natriuretic peptide, sodium loss occurs, but water gets retained in our body, so it causes hypotonic overhydration. After that, we have fluids and electrolyte. Average daily water balance in our body. For a 70 kg of body weight, different output and intake. Urine, we usually output from our body is divided into three types. Urine, we usually 1500 ml, insensible loss is 900 ml, and feces is 100 ml. While intake is water from beverage is 200 ml, water from food is 1000, and water from oxidation is 300 ml. And types of fluid that we can administer in our body, it is mainly divided into two types, that is crystalloid and colloid. This division is based on the basis of ability to cross capillary endothelium, as crystalloid can easily cross capillary endothelium. So crystalloid is a aqueous solution of low molecular weight electrolyte, and replacement ratio of crystalloid for blood loss is 3:1. If 100 ml of blood is lost from our body, we have to administer at least 300 ml to replace the lost blood. And T half of crystalloid in plasma is 20 to 30 minutes, and it is very cheap as compared to colloid, and there is no risk of anaphylaxis associated with crystalloid. And different type of crystalloids that are available are isotonic to our body, hypotonic to our body, and hypertonic to our body. And isotonic, we have got normal saline, ringer lactate, and Hartmann's fluid. And in hypotonic, mainly is 5% dextrose, and hypertonic is 3% NS and 6% normal saline. and different composition of our fluid is 5% dextrose contains only 5% glucose solution, whereas in normal saline 154 ml, it contains 0.9% so sodium chloride, that is 154 millimoles of sodium chloride, and Hartmann solution contains 131 millimoles of sodium, 111 moles of chloride, 29 millimoles of lactate, 5 millimoles of potassium, 5 millimoles of calcium. uh, 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 it is the most isotonic saline, Hartmann's and Ringer's lactate as most physiological saline, most physiological to our body fluid. Same is written here, that is a normal saline composition is and Ringer lactate, Hartmann's and plasma light composition. Difference between mainly normal saline and Ringer lactate is that normal saline only contains sodium and chloride, whereas Ringer lactate contains all the ions like sodium 130 millimoles, potassium 4.5, calcium 2.7 millimoles, and chloride 109 millimoles. Uses of crystalloids. It is mainly used as fluid and electrolyte supplements to patients in our wards. And hypotonic is a 5% dextrose. Use of dextrose is as dextrose can easily is easily metabolized in our body. So only remaining after administration of dextrose is that is free water. It can easily diffuse anywhere, and it doesn't remain in intravascular space, so it's not a good choice for during resuscitation, and it cannot be used to achieve perfusion in the patient as a replacement fluid for the blood space. It is mainly used in case of dehydration, whereas the hypotonic saline like 3% NaCl and 6% NaCl, it is mainly used in case of treatment of hyponatremia and hypovolemic shock. Colloids. Colloids are the aqueous solution of high molecular weight substances. It cannot easily pass through the capillary wall. So replacement ratio for this is 1:1. If 100 ml of blood get lost, so we have to give only 100 ml. So, and its T half is much more as compared to crystalloids. T half in plasma is 2 to 8 hours, but it is very much expensive, and there is also a risk of anaphylaxis associated with colloids, because some colloids can cause impair in coagulation profile, and some are also nephrotoxic. So type of colloids that are available are natural and artificial, that is blood substitutes like FFP and human albumin. Artificials are starch and gelatin. Mainly the use of colloids are during resuscitation, and different composition of colloids as in dextran contains sodium 154 millimoles of sodium and chloride. And the perioperative fluids, the nature and type of fluid replacement therapy will be determined by individual patient needs. A typical daily maintenance fluid regimen consists of 5% dextrose with either Hartmann's or normal saline, and the nature and volume of these fluids are determined by a careful assessment of the
Berul,
patient.
this will be covered by the next speaker, Berul. This
Yes.
fluid management is covered by the third speaker. Have you any other point to mention about the how this fluid balance is maintained in the body? What are the hormonal influences? What happens if there is a loss? So these will be taught by the third speaker.
Yes, sir. The homeostatic blood regulatory mechanism gets activated in case of blood loss. That is from the renals.
What happens
Yes.
if you have a blood loss or a fluid loss in the body? How does the body tries to compensate for that? What are the different compensatory mechanisms in the body?
Sir, different compensating mechanism includes from the renal system, and
Yes.
renal system will try to decrease the total urine output from our body. The adrenergic system will constrict the blood vessels, so the majority of the blood fluids will go to the vital organs of our body. Yes, sir.
What else? Some hormonal influences come into play.
Yes, sir. Secretion of in case of secretion of adrenaline from our body, and natriuretic
What
peptides from.
if you say in one word, in one sentence, what happens to the different hormones in the body in response to a stress of surgery or stress of trauma? In one sentence, if you'd like to say that, all hormones in the body increases except
Yes, sir.
except what? Except insulin.
Yes, sir. Yes,
Except
yes, sir. Yes,
insulin, all the hormones in the body are raised in response to stress or trauma. So all
yes, sir.
these
Yes.
hormones has some effect. Like aldosterone has some effect. You talked about that. What happens in the
Yes, sir. Yes.
kidney?
In kidney, aldosterone gets activated, which causes water absorption from the
Not only water,
collect
and not
water
only water.
water and electrolytes absorption from the
Sodium.
starting.
It
Yes, sir.
absorbs
Sodium.
sodium. It absorbs potassium.
Yes, sir.
Okay, but these
Sodium.
are the important things in physiology. You see, you have talked of three body compartments:
Yes, sir.
intravascular, interstitial, intercellular.
Yes, sir.
You could have shown this. Uh, you have shown the box where all the electrolytes are mentioned, and how are the three compartments remain in balance? What is the mechanism?
Yes, sir. Yes,
There are
sir.
two things. One
Yes,
is
sir.
ionic charges.
Yes, sir.
The total ionic charges, some are positive, some are negative.
Yes, sir.
Suppose there is leak of sodium,
Yes, sir.
there is loss of sodium. What happens? Sodium drops in the intervascular compartment.
Yes, sir.
So what happens? The intervascular fluid become hyperosmotic, hyposmotic.
Sir, hyposmotic.
So how body tries to compensate for that?
Sir, body will try to shift the amount of water from intravascular space to the interstitial, to the surroundings like interstitial spaces and to the cells of our body. The shift of water occurs from hypertonicity to hypotonicity.
So the fluid will now shift from interstitial to the intravascular.
Yes, sir.
So these are the important things. Body
Yes,
physiology.
sir.
First is
Yes,
what is the
sir.
relative concentration of different balance.
Yes, sir.
And if there is a disturbance, what happens to each of these maintained by kidneys by sweating?
Yes, sir. Yes.
And the
Yes,
part
sir.
will be talked about by the next speaker. Okay. So we pass on
Yes.
to the next speaker, Dr. Sritama. No, so Dr. Sudipta, who will she's from Apollo Hospitals, second year, first year junior resident. Sudipta will speak on the different disorders of this fluid electrolyte in surgical patients, so that we can plan the therapy depending on this. Sudipta, you confine to the disorders, and there you can share your screen and start. Dr. Bhattacharya, you have joined. Dr. Bhattacharya could join.
Yeah, I have joined.
Yeah, okay. Just we have finished the first part.
Yeah.
He need to speak on more on the therapy, but I told him the basic part of the physiology of electrolyte is the body fluid compartments, their maintenance, and if there is a disturbance, how the body tries to compensate for that. You like to add anything on that, Dr. Bhattacharya?
Hello.
Yes.
Could I?
Yeah, Sudipta, you can start. You can
No,
share screen.
I wanted to
Yes,
ask the previous speaker as to
Yeah.
what the question you were asking him about.
Yeah.
But he didn't talk about a hormone that is released from the posterior pituitary. What is that particular hormone which is released from the posterior pituitary, which helps in preserving water in electrolytes?
Sir,
in a situation
vasopressin,
where
sir.
there is, yeah,
Vasopressin, sir.
yeah,
Yes, sir.
vasopressin. So when sir
Yes.
asked you when there is a loss of fluid, in the post-operative period, how the body tries to compensate for that, that was one of the things you should have mentioned, isn't it?
Yes, sir. Yes, yes, sir.
And just is assessing the, I mean, requirements of total fluid requirements is part of your topic, was part of your topic.
Yes, yeah, yes, sir. The maintenance fluid and the how to calculate the
So
amount. Yes, sir.
how do you calculate the amount of fluid that is required for an individual in the, say for example, in the post-operative period? How do you calculate the maintenance amount of fluid that is required?
Sir, using the Holiday Seger's formula, that is 4:2:1. For
Okay.
yes, sir.
Yes.
4 ml per kg of body waste for the first 10 kg of the body, 2
Okay.
ml per
Okay.
kg for.
Any
Yes,
other
sir. Yes.
way of calculating?
Hello, sir.
Any other way?
Sir.
Any other way of calculating? One is that formula, 4:2:1 formula. Any other
Yes,
way
sir.
of calculating the total fluid requirement?
Another way, sir, as total, matlab, 30 to 40 ml per kg of
Very
body
good.
weight. Yes, yes,
Yes.
sir. General dictum, sir. Yes, sir.
So 35 ml per kg per
Of
day
the
is
body
the
weight.
requirement, usually requirement.
Yes, sir.
That
Yes, sir. Yes, sir.
amounts to approximately 2,500 ml of fluid per day. Now,
Yes, sir. Yes.
how do you now calculate? I mean, that you have calculated this total fluid requirement. Now, how do you
Yes, sir.
divide it into different types of fluid as you were talking about?
Yes, sir. We'll
Say,
divide in the. Yes, sir.
in the first post-operative day.
Yes, sir.
This will be Dr. Bhatta, this will be
This
first
will-
speaker.
Oh,
uh,
okay. Sure.
First speaker.
Sure.
So, Sudhita, you can start.
Hello, sir.
Thank you, sir.
Am I audible?
Yeah, you're audible.
Hello. Uh, hello, sir. Sir, sorry for presenting like this. Sir, I am Dr. Shudipta Mukherjee from Apple Hospital, and I am going to present disorders of fluid and electrolytic disorders in surgical patients. In introduction part, human body is made up predominantly of 50 to 70% of water, which is depending upon age, gender, and body fat. Body water can be divided into intracellular compartment and extracellular compartment, and majority of the body fluids are present in.
Sudhita, these are covered. You skip.
Okay,
Come on to the main part.
Okay, okay, sir. So from maintenance fluid, maintenance fluid, maintenance fluid.
Shock of disorders.
Okay, sir. Post-operative fluid management. The fluid should be to be titrated to maintain an adequate urinary output of 0.5 to 1.
Sudhita, you are supposed to speak on electrolyte and fluid disorders. You talk of how do you diagnose overhydration, how do you diagnose dehydration, what are the different electrolyte changes in the body. So we talk of those first, and then the management comes. You're not clear about the topic. You are supposed to speak on the electrolyte disorders in the surgical patient. There are some situations where surgical patient has some defined electrolyte disorders and need to address those. Am I audible? Sudipta. Hello?
I think he got disconnected.
Yeah.
Yes, he's got disconnected, sir.
Yeah. Just wait for 1 minute and see. Milind, I think his topic was that only. No?
Yes, sir, disorders. His topic was disorders, and the next speaker
So
was
you should speak
covering
on that defined disorders which are there in surgical patients, and then you can discuss about the management of that part. Let's see whether he can join or not. Sudipta, you could join.
I think somebody should call him up.
Yeah, Milind is calling.
Yes, sir, I'm trying to get through to him.
Yeah.
Next, sir.
Okay, I think Sritama can cover. Okay, when the Sritama will speak on the management, I think she should touch the basic thing, what is the abnormality and how she is correcting it. If Sritama is not connectable, we can. Sritama, you are ready?
Yes, sir, I'm ready.
Okay. We start with Dr. Sritama Rai, who is a first-year junior resident at Ruby General Hospital. So, Sritama, you can share your screen and try to give us what is the disorder status and how you are planning the therapy. Okay. So,
Yes,
Sritama,
sir,
you can share your screen
okay.
and start.
Because, sir, I did not cover much on the disorders part actually.
Okay,
But,
fine. Okay. But he is disconnected. You cannot continue with him.
yes, sir. Okay. Share. Okay.
Her topic is on.
Sir, my topic is on the treatment part.
Okay. Treatment of fluid and electrolyte disorders.
Yes,
Yeah.
sir. Moment.
So whenever you speak of, say, for example, a particular electrolyte disorder, the management part, you can,
Yes, sir. I'll try.
yeah, put up a few points regarding its symptoms, diagnosis, causes.
Sir, is it visible?
Yes, yes.
Yeah.
You can start.
Okay. Good morning, everyone. I'm Dr. Sritamara, and I will be presenting a short topic on the treatment of fluid and electrolyte disorders. So, the main I'll just first summarize what are the different cations and anions that we basically put careful attention on while maintaining fluids in our body. So main intracellular cations are potassium, magnesium. Main intracellular anions are phosphates and proteins. Main extracellular cation is sodium, and anions are chloride and bicarbonate. We have different routes of fluid loss. Lungs excrete about 400 ml of water in expired air every day. The excretion is increased in dry atmosphere or in patients with a tracheostomy. So we should pay attention on how to keep moist air supply in patients. Through skin, we excrete about 600 to 1 liter of water a day through sweat. Through
Not
feces,
excrete, we lose.
we use.
We lose. Yeah.
Okay, we lose. Yeah, sorry, sir. Through feces, we lose 60 to 150 ml daily in normal bowel habits, in people with normal bowel habits, and through urine, we lose about 1.5 liter a day for a person with a healthy kidney. In adults, approximate daily requirements of some electrolytes are as follows. We require 50 to 90 millimole of sodium per day, 50 millimole of potassium per day, 5 millimole of calcium per day, and 1 millimole of magnesium per day. what are the factors that are needed to factors that we need to consider to assess the fluid requirements of patients? First, we need to assess the vitals, if pulse, BP, central venous pressure, if we can measure. Clinical examination to check the hydration status of the person, measuring the skin turgor, the peripheries, urine output, specific gravity of urine if possible, urine and serum electrolytes, and the hematocrit value. We have to estimate what is the already incurred loss by the body through vomiting, through paralytic ileus, through diarrhea, through excessive sweating, by intravascular fluid shift from burns or other serious inflammatory conditions like infections, intestinal obstruction, sepsis, etc. We have to estimate what amount of supplementation should be given by anticipating fluid loss through drains, through fistula like enterocutaneous fistula, and through NG tubes, or through abnormal urinary or fecal losses. Abnormal urinary or fecal losses include, abnormal urinary or fecal losses like fecal losses through enterocutaneous fistula, through proximal stoma like through stoma from the ileum or from jejunum, which exudes abnormal amount of water because water absorption doesn't take place, or abnormal urinary loss includes urinary losses through disorders like SIADH and other hormonal malformations, hormonal malfunctions, and also urinary losses through, there's some fistulas through which we have to, when if bladder obstruction, if suppose a patient has a bladder obstruction, we have to make alternate route for the urine to pass through the skin, so that
No,
it
I think
comes out.
your point is all right. That is abnormal urinary
Yeah.
and fecal loss.
Yeah,
Suppose
yeah,
patient is having diarrhea, that is over and above what is the normal amount of fluid that is lost through stool.
yes, yes.
Okay. So someone is having diabetes insipidus or diabetes mellitus, you'll be having
Yeah.
a loss over and above the normal loss
Through the
of
urine.
urine. Yeah.
So now, estimating all of that, we have to do the perioperative fluid management, that is preoperative and postoperative. So body water in humans have about 50 to 70% of water, and the precise percentage of water is affected by the gender, the age, body fat, and lean body mass. So the male gender has more body water. Extremes of age like childhood and elderly have more body water, and people with more body fat have more body water, and lean body mass also allows to
No, I
absorb.
think you are wrong there. Patient with lot of fat will have less body water. For example, if 60% of the total body weight is water for males, it will be 55% for female because fat
Oh,
hardly contains any water.
yes,
Fat
yes.
do not contain much water. Yeah.
Sorry. Okay. The body water compartments are divided into intracellular, that is 30 to 40% of the total amount of water, intravascular, which contains 5 to 7%, and the interstitial volume is recirculated by the lymphatics. So maintenance fluids for routine preoperative care is basically by maintenance drip of crystalloids. It's primarily measured by the Holiday-Segar 4:2:1 rule. That is weight less than 10 kgs have an hourly amount of 4 ml per kg per hour. Weight over 10 to 20 kgs has 40 ml plus 2 ml per kg for every kg increase over 10 kgs, and weight for over 20 kg has hourly value of 60 ml plus 1 ml per kg for every kg over 20 kgs.
Is it? Does it mean? You go back to that slide once again. Is it this formula means weight less than 10 kg or for the first 10 kg?
For the first 10, sir.
Yes,
Just
for the
to
first
start.
10 kg.
For the first 10 kg.
Yes. Then for the next 10 kg and then beyond, isn't it?
Thank you.
Also
Yes,
to ensure.
yes, sir.
Not
Uh,
wait for those less than 10 kgs. That I mean, if you speak like that, the interpretation may be different.
yeah, yeah, right. Um, So, maintenance fluids, according to Saviston, maintenance fluids have not been rigorously tested. So, the ideal fluid for our body is still unknown. Current standard is to use 5% dextrose in half normal saline with 20 milliequivalent per liter of potassium. Source of the standards formulation is still unclear. So right now the recommended maintenance fluid contents is water 2760 ml, dextrose is 132 gram, sodium is 203 milliequivalent or 11.2 gram, potassium is 53 milliequivalent or 1.9 gram. But
Can you can you go back to the previous slide?
yes sir.
Hello. Can
Yes
you
sir.
go back to
This one?
yes, 5% dextrose with half. Yeah, that one. Yeah. So can you clarify this a little bit more? Like, what do you actually wanted to mean here? So maintenance fluids, as you said, is you can calculate by that formula,
Yes
or
sir.
a simpler way is to just multiply the body weight into 35.
35, yeah.
Yeah. So
Yes sir.
if suppose a person is 70 kg of body weight, you multiply with 35, that comes to about roughly around 2500. Okay.
Yeah, yeah.
2500 ml. Now you have to calculate what particular fluid, so you have got so many types of fluid with you. Dextrose, starting with dextrose, normal
Yeah.
saline, half strength normal saline, everything is there with you.
Yes,
Now you have to choose which one to give, which one to advise.
yes
See,
sir.
out of this 2500 ml, as you said, that there is a loss of pure water, only water, no electrolytes.
Yeah.
Roughly around 500 ml from the where?
Well, from lungs, sir.
Yes, from the oral mucous membrane, from the lungs
Yeah.
with respiration. That is pure water.
Yes, sir.
So that pure water is basically what we have is 5% dextrose, because once you give 5% dextrose into the body, so that the dextrose will be metabolized. What will be left is only water.
Water.
So we can that is about 500 ml. So we are left with around 2000 ml more.
Yes,
Okay.
yes.
So this 2000 ml, what would be the best type of fluid?
Sir, for then we have to choose what is most physiological for our body, sir.
Yes. Yes. Which one? So what will be the most? It will be having electrolytes as well as it should be isotonic.
Yes, sir. I have that in the following
Okay.
slide.
Okay.
Yes, sir.
Go.
Okay, you carry on. Carry on the presentation.
Yeah. So, as I said, this is the recommended maintenance fluid content, but the normal needs for a 70 kg man per day is water 2000 ml, sodium 2 to 4 gram, and potassium 100 milliequivalent as compared to the former. Post-operative fluid management. 1 minute, so I'll just check where that part is. Okay. Okay, it's there. It's there. Post-operative fluid management. So patients with minimal intraoperative blood loss and with adequate fluid supplementation and adequate urine output have no necessity of IV maintenance fluids. Postoperatively, for some factors that can affect the body is bolus fluid supplementation. So, bolus fluid supplementation basically confuses the body's compensatory mechanisms largely because, like, if we suddenly supply 1 liter of normal saline or 1 liter of ringer lactate to the body in a bolus, the body is unable to compensate properly because it has to fluctuate largely with a large amount of bolus supplementation. But whereas if we supply fluid in a proper measured hourly rate like 4 hourly or 6 hourly, the body is able to compensate better. Post-operative hypovolemia basically occurs due to an ongoing inflammatory response which increases the intravascular permeability, resulting in interstitial fluid buildup by excretion of water through the intravascular compartment to the interstitial compartment. Factors to help determine maintenance fluid in ICU and elderly patients. This is maintained by. This is basically measured by the BUN ratio. So if BUN ratio is over 20, we estimate a pre-renal renal failure, and if the BUN ratio is less than 10, we estimate understand it's a renal failure, and we give fluid supplementation accordingly. The other factors are urine output, which gives a direct measure of hypovolemia status in the body, central venous pressure, pulmonary capillary wedge pressure, stroke volume, and the cardiac output. So low urine output basically is a picture of low maintenance fluid status. So in this case, what we basically have to do is increase the amount of maintenance fluid, but some prefer to give a bolus furosemide. But bolus furosemide basically is a loop diuretic, and which further retains. So if we give bolus furosemide, it results in increased excretion of water due to the diuretic effect, but it further retains the fluid in the body due to the compensatory RAS mechanism, because if we are excreting urine from the body while there is already low fluid maintenance fluid in the body, the RAS mechanism starts acting, and the renin-angiotensin system basically acts in retaining the amount of fluid whatever is left, which suggests that increasing maintenance fluid is the right way to go for low urine output status. So fluids, we have lots of fluid like normal saline and ringer lactate, which is primarily used in a lot of hospital situations. Fluids like plasma light and normosol R have been found to resemble contents of the electrolyte in blood more when compared to normal saline or ringer lactate. So normal saline causes a chloride overload by causing a hyperchloremic acidosis. Sorry, sir, you're saying something?
No.
No, carry on.
Normal saline causes a chloride overload by causing hyperchloremic acidosis. Plasma light, on the other hand, reduces need for frequent electrolyte replacement of calcium, potassium, or magnesium, since it has been found that it contains more physiological values of these electrolyte supplements. So now I'll move on to the fluid and the electrolyte balances. Predominant electrolytes that I'll be talking about is sodium, potassium, calcium, and magnesium balance. The normal range of sodium in the body to be maintained is about 135 to 145 milliequivalent per liter. Sodium balance is heavily controlled by antidiuretic hormone, which is secreted by the posterior pituitary. Hyponatremia is found to be more concerning than hypernatremia, and diagnosis is has to be made by blood test only, because no specific symptoms of sign is clearly indicative of a hypo or hypernatremia status. Treatment of hyponatremia. Hyponatremia is of three types. Mild hyponatremia is 130 to 138 milliequivalent per liter of sodium. Moderate is 120 to 129 milliequivalent per liter, and severe hyponatremia is less than 120 milliequivalent per liter. I have talked in short about one or two different kinds of hyponatremia and how they will be managed. Dilutional hyponatremia that occurs in patients with hyperglycemia draw out water into the ECF. So what happens is patients with hyperglycemia have a hyperosmotic status, and resulting in drawing out water from the intravascular fluid. Sodium falls by 1.6 milliequivalent per liter for every 100 milligram per deciliter of glucose over 100. So transitional hyponatremia occurs, causing no change in the actual body water, and it is basically corrected by plasma glucose level itself. So if we correct the plasma glucose level, we don't need to worry about the hyponatremia because it will get corrected automatically, and we don't need to independently pay attention to the sodium status.
This is also called pseudo hyponatremia, isn't it?
Yes, sir, pseudo hyponatremia.
So if a patient is diabetic and having features of hyponatremia, I mean on electrolyte, hyperglycemic, showing low sodium, so that has to be corrected.
Yes, sir.
Isn't it? There is a formula, as you said, 1.6. There is a formula for correction of sodium in a patient with hyperglycemia.
Okay, sir.
You know that?
No.
It is blood sugar into 0.016 plus the serum sodium that is being reflected. Okay, that will give you the corrected sodium in a patient with hyperglycemia.
Okay, so renal losses that occur in patients with diabetes insipidus or in patients with where else is there? Renal losses. Just a second, so let me recall. Renal losses. Renal losses occur in patients with cerebral injury when there is excessive natriuretic peptide like ANP or BNP release. Their sodium losses can occur through renal system, and there is also increase of ADH in this condition to interact, basically to counteract the rapid fluid loss in the body. And in these cases, sodium needs to be replaced through IV line or enteral intake. In patients with SIADH, when there is inappropriate ADH secretion, there is basically retention of fluid in the body that causes in SIADH, there is a retention of fluid in the body.
Water retention.
Water retention in the body because ADH doesn't only works the compensatory mechanism, but it acts otherwise also. And in these cases, it basically can be seen that ADH occurs in surgical ICU patients mainly, and this has to be managed with fluid restriction to counteract the buildup of fluid in the body. Now, in hypernatremia is divided into mild, moderate, and severe. Mild is more than 145 milliequivalent per liter. Moderate is 146 to 159 milliequivalent per liter, and severe is over 150. In hypovolemic patients with hypernatremia, replenishment with isotonic fluids balances the fluid status. And in hypervolemic patients with hypernatremia, diuretics have to be used, but they have to be used judiciously. Acute hypernatremia occurs where sodium replacement is done at a rate of 1 to 2 milliequivalent per liter, and chronic replacement is 0.5 milliequivalent per liter. And sodium correction should not be done more than 8 milliequivalent per day to prevent central pontine myelinosis, which is found that in post-URP patients, we have when we try to correct the sodium status very rapidly, then there is a precipitation of brain injury, central pontine myelinosis, and that is why it has been said that sodium correction should be done judiciously.
Especially with hypertonic saline.
Especially, hypertonic saline. If we use 3%.
Chitama, we have 5 minutes more. So come on, quick, go to the main parts.
Okay, sir. Patients with DI should be treated with desmopressin, which is a synthetic analog of ADH, but with only antidiuretic property and no vasoconstrictive property like ADH. Potassium imbalance like hypokalemia has to be done. Hypokalemia is less than 3.5 millimole per liter. Replacement is done orally by 40 to 100 milliequivalent per day and IV through 10 to 20 milliequivalent per hour. Frequent monitoring is necessary as cardiac system is heavily associated with potassium imbalance. Therapy is given as chloride salts since hypokalemia is associated with contraction in extracellular water in which chloride is predominantly the predominant anion. Magnesium monitoring is also required as hypomagnesemia can cause refractory hypokalemia. Patients with DKA, that is diabetic ketoacidosis, on insulin therapy need potassium supplementation since insulin causes hypokalemia. And in patients on diuretic therapy like loop diuretics, additional potassium-sparing diuretics like spironolactone need to be given to correct the hypokalemic status. Hypokalemia is measured more than 5 millimole per liter. Cardiac arrhythmia can occur from hyperkalemia. So calcium supplementation is given to reduce the risk as calcium antagonizes the depolarizing effect of potassium. Bicarbonate therapy is found to be most effective in metabolic acidemia. Aldosterone deficiency and hyperkalemia, when associated together, their mineralocorticoid like fludrocortisone raises the renal excretion of potassium. Since aldosterone acts as aldosterone deficiency prevents the excretion of potassium, we use mineralocorticoids like fludrocortisone for the same function. In patients with acute renal failure, dialysis is the only option to correct the potassium level. In patients with hyperkalemia with renal dysfunction, oral or rectal administration of sodium polystyrene sulfonate is used since it binds potassium in the gut lumen, thus preventing the hyperkalemia in blood. Calcium imbalance. Hypocalcemia is defined as total serum concentration of calcium less than 8.4 milligram per liter deciliter, or measurement of ionized calcium concentration less than 4.5 milligram per deciliter. Treatment of acute symptomatic hypocalcemia is done by prompt calcium infusion in the form of oral or IV calcium gluconate or calcium chloride. But calcium gluconate is preferred since it causes less tissue necrosis on extravasation. The first 100 to 200 milligram is given over 10 to 20 minutes. Faster administration causes cardiac dysfunction, often leading to a cardiac arrest. It should be diluted in saline or dextrose to avoid vein irritation. And infusion should not contain bicarbonate or phosphate, as they may form an insoluble calcium salt. So bicarbonate or phosphate supplementation have to be given separately. Coexisting hypomagnesemia need to be treated, and magnesium is given by infusion as 2 gram magnesium sulfate in 10 to 15 minutes, followed by 1 gram per hour. Chronic hypocalcemia by hypoparathyroidism is treated by oral calcium and vitamin D. Usual initial dose of vitamin D is 50,000 interfunctional units of 25 hydroxyvitamin D. And if renal losses occur of calcium, thiazide diuretics, which basically act as retention of calcium, are added to retain calcium excretion. Hypercalcemia by parathyroid adenoma is corrected by excision of diseased tissue. Thiazide drug-induced hypercalcemia needs to be altered by therapy, different medication therapy, like loop diuretics which lose calcium. Malignant neoplasm causing hypercalcemia needs surgical excision of the malignant disease or radiation and chemotherapy. Symptomatic patients of hypercalcemia has to be promptly corrected by saline infusion to raise the intravascular volume, followed by loop diuretics to induce a saline diuresis associated with urinary calcium clearance. Severe hypercalcemia more than 14 milligram per deciliter due to malignancy basically results from calcium released from bone by tumor. It is managed by bisphosphonates like zoledronate, alendronate, pamidronate, etc., which reduce the osteoclast-related release of calcium from bone. And exogenous calcium is used for short-term control of hypercalcemia. And basically calcitonin retains the calcitonin takes the calcium out of blood and deposits to the bone. Magnesium correction. Hypomagnesium is, if mild, is treated with oral replacements. Symptomatic hypomagnesemia is treated by magnesium infusion. Most common treatment is by magnesium sulfate, where 1 gram contains 0.1 gram of elemental magnesium. 8 to 12 gram of magnesium sulfate in first 24 hours is given, followed by 4 to 6 gram per day for 3 to 4 days. But it should be done cautiously in renal insufficiency, and dose should be reduced by 50 to 75% of baseline. Magnesium supplementation should be monitored. Magnesium hypomagnesemia should be, and hypermagnesemia should be monitored closely for deep tendon reflex disorders. Potassium sparing diuretics have been helpful in chronic hypomagnesemia. Severe hypomagnesemia, that is less than 1 milliequivalent per liter, requires sustained therapy because of slow equilibration of ECF with ICF stores of magnesium. Hypermagnesemia is commonly found in patients with renal failure. In patients with intact renal function, stopping magnesium infusion with help or supply with help will help recover patients. And severe hypermagnesemia is treated with calcium gluconate, like in hyperkalemia. That is calcium gluconate 10% is given, 10 to 20 ml for 10 minutes, and patients are given 100 to 200 milligram of IV elemental calcium during 5 to 10 minutes, first 5 to 10 minutes. For renal clearance of magnesium, loop diuretics and saline diuresis is used, although there is no supporting literature to prove this. In renal insufficiency, dialysis is used. Intermittent hemodialysis is found to be more effective than peritoneal hemodialysis or continuous renal replacement therapy. So that's all in short. Hello, sir.
You have covered. Yeah, you have covered all the topics very nicely.
Okay, sir.
Except I think the water balance part, which Professor Shaha was asking you about, what is overhydration, and few words would have completed it totally actually.
Okay, sir.
Water excess and water deficit.
Yeah,
Yes.
and Shitama, you mentioned about the absolute values like sodium 200, potassium 70. There is nothing like absolute values. This is calculated as per body weight. Sodium is 1 to 2 milliequivalent per kg per day.
Yes, sir.
Potassium is 1 milliequivalent per kg per day. So is 200 sodium will be little more if you go by body weight calculation. Okay, so these are not absolute values. These are dependent on the body weight for the requirement. And for post-op, this most important part, I was expecting that you would talk more little on post-op fluid management, because post-op fluid management depend on the immediate post-op period.
Yes,
and
sir.
then once the stress is over, sometimes we need to maintain the patient for fluid for 3, 4, 5 days.
Yes, sir. Yes,
So
sir.
in that case, the fluid therapy will change. The immediate fluid therapy is
Yes, sir. Yes.
guided by the pre-op-loss, intra-op-loss, and the metabolic stress.
Yes.
When the stress goes down, the fluid therapy should also change.
Yes,
So,
sir. Yeah.
we take a faculty lecture on basic aspect of electrolyte disturbances. So we have a gross idea about the different body fluid compartments,
Yes, sir.
the disorders, and the optimal management.
Yes, sir.
I think we are running out of time. Dr. Bhatt, any last minute comment?
No. Everything has been covered. I think only part that I was trying to ask her about was the choice of fluid. What would have been the better choice of fluid? Say, we had said the 2,500 ml is the 24 hour. Like as I said, the initial 24 hours, there is release of ADH post-op. I'm talking about post-op phase. So there is release of ADH. So there is some amount of water retention, both sodium and water retention.
Yes.
So not much electrolytes may be required. And there is also liberation of potassium because of the tissue injuries. So potassium is not required. Potassium is required from the third day onwards.
Third day onwards.
So yeah, third day onwards. So initial part, it is better. The best way would be what is called an half strength normal saline, which contains about roughly around 77 milliequivalent of sodium and 77 milliequivalent of potassium. That if you calculate the total requirement of sodium, it will come to around that the same thing, about 2 liters of half strength normal saline plus 500 ml of 5% dextrose. That will come, and from the third day onward, you can start adding 20 milliequivalent, that is 1 ampule of potassium chloride in any of the thrice daily, any of the running fluid bottles.
Okay, sir.
So that will be from the third day
And-
onwards, potassium can be supplemented, and the initial pair, the half strength normal saline will be the best form of fluid to cover up your.
Yes, sir.
and one should not forget that in the immediate posture period, all
Yes.
patients require an obligatory intake of at least 100 grams of dextrose to
Yes.
maintain the basic metabolic functions like brain functions, cardiac functions, renal functions, skeletal muscle functions. So
Yes.
100 grams of dextrose has to be given average adult patient to supply 400 kilocalorie of energy to maintain the basic functions. I find a lot of people are not giving dextrose. They put just one ringer or normal saline, 2 liters to 1, which is a very erratic fluid management. You should always consider giving at least 100 grams of dextrose in the immediate posture period. That is important.
Okay, sir.
I think I must thank Dr. Varchaj and all the speakers. Sudipto could not connect. So I thank you all. So we have published the July roster for classes. We have given little few dates because July we have state conference. We have not given any class on the July. And on Saturday we have a laparoscopy workshop at NRS, which will be relayed from Mumbai. All DNB students can join there also. Okay, just register your name with NRS. Okay, thank you.
Yes, sir.
We say it a day. Thank you, Milind.